Okay, we'll turn it over to Dr. Eastman, who's going to present what will probably be our final case of the morning session.
Okay, thanks, Mark. And so we'll start with just some objectives for this case. I think the importance of really hitting home all the points of truly understanding the diagnosis will kind of set you up for success and plan based up all the subtle details of where you're going to be able to see and sequencing of your reduction and fixation, I think is paramount. And so I think the main point we'll be discussing here is the optimal strategies for each patient and injury in terms of addressing the marginal impaction that we can see. And so our patient here is an 84-year-old with some medical problems, as you see listed, primarily I think with his heart, hypertension, and then some dementia. He had a ground level fall with some isolated left hip pain. He is stable otherwise, but here's his injury, AP pelvis in the ER. And so you can see there's been a disruption of both the ilioischial and iliopectineal lines. You can see extension of his anterior column fracture line extending up onto his iliac crest. We're already getting a sense of some comminution on that quadrilateral plate and working down the posterior column. And then as we look through his other series of the 5 views of the pelvis that were obtained, you can see a large segment of dome impaction that we can see here. And so looking through both his Jude A views as well, you can see that same segment of dome impaction. And then just some very select CT cuts. Again, you can see the displacement of the iliac crest. That arrow in the top middle picture is pointing to what I'm considering to be some intact cartilage. There's no continuation of the fracture line that fully goes out the posterior acetabular surface, but we're going to see on our intraoperative imaging that maybe that cartilage isn't truly intact. And I don't think it's semantics. I think really understanding the fracture pattern and some of the very subtle differences between the associated both column and the anterior hemitransverse or real need to be appreciated. But then again, we can see a large segment of the cranial dome impaction that we can see here. And just some select CT scans of surface rendered images. We can again see what we saw in our AP pelvis with the extension of the anterior column going up. We can see that it's somewhat incomplete on the internal iliac fossa. And then looking at our Jude A views, again, we can see some of the details. And again, just highlighted because I think the focus we'd like to discuss on this case is that large segment of dome impaction and how to best deal with it. And so I think it'd be great just hit home some of these points and maybe get some faculty input in terms of the diagnosis. Initial treatment, I think we've talked about with some of the other patients today in terms of the role of traction, and then start talking about a sequence in terms of surgical approach, and then really how to deal with that impaction. Mark, do you want to make any comments or questions?
Well, I think that the first question obviously is going to come up. Is this patient an amenable patient to internal fixation, to weight-bearing restrictions post-operatively, to post-operative compliance? Is he a surgical candidate? And if so, is he a surgical candidate for internal fixation or arthroplasty or a combination of both? And how do you decide in an elderly patient with multiple medical problems, including dementia?
That's a great question. I'm happy to take that if any of the faculty wants to contribute.
Are there any fracture pattern characteristics where you look at it and you say, oh, this is definitely more of an arthroplasty consideration, or is it just patient related?
I think I'll go first. I think that it's a whole picture. I mean, I think the patient itself comes into play in a big part. I mean, if someone, I think age is just a number, and if someone is chronologically old but physiologically young, that's a much different picture than someone who's younger but with a whole host of comorbidities and functional levels that go along with that. And so I think that comes into play, but then also all the fracture patterns that we've talked about in terms of impaction, femoral head damage, comminution, all those things come into play in terms of whether you can truly obtain an anatomic reduction. Then also, even if you can, what's the longevity of the cartilage that's underlying that, and is it viable? And so there's been studies that have looked into prognosing or making a prognosis for those patients, trying to get some sort of idea of predicting the risk of post-traumatic arthritis. But again, I don't think that's the most accurate tool. And I think every time it's putting all those pieces of the puzzle together to try to come up with a patient-centric decision for that.
Yeah, I think if you were to look at the nomogram paper that Marius Keel wrote up, this patient is going to be a very high risk for post-traumatic arthritis. But for me, I think some of the important factors, Mike, maybe you can mute yourself for a sec. Most important factors would be femoral head injury, femoral head damage, and then also the nature of the impaction. In your case, it appears to be a very large single impacted segment, which is potentially a much friendlier situation for reduction than the situation of the same volume or the same surface area of impaction, which is in multiple fragments going in different directions. And we oftentimes will see that situation as well. I find that a much more difficult situation to obtain a reduction and to also maintain it. Other thoughts from the faculty?
Agreed. Very good points.
Yeah, I think that's a good point, is that the ability to obtain it is one thing, and then the ability for it to stay in place, especially in these osteoporotic individuals, is another one. I think it's very challenging to keep that in place with a patient that's demented and unable to follow postoperative protocols. And that's typically an indication for me to look towards arthroplasty if I think that the patient can tolerate that.
I think the other factor is the size of the anterior column component. So this one is incomplete. It looks like one of the extensions is into the interspinous notch. And the smaller the anterior column component becomes, to the point that's becoming an anterior wall, the less available real estate you have for stable internal fixation. And at least my experience with anterior wall fractures in older patients has been miserable, especially when they're associated with marginal impaction. So if you got a big anterior column you can make stable, which is going to buttress your marginal impaction segment, I think that's a favorable factor. But the closer you get to the joint with the anterior column, the worse the outcome, in my experience, at least.
For me, this is a situation where I think you have to be cognizant of how long you're going to be in the operating room. And, you know, sometimes I've made the mistake of saying, well, I'll treat it like sometimes a proximal humerus, maybe try to fix it. And then if that doesn't work, go to a total hip. And the problem with that is just timing and the OR sequence. So for me, the question is always, what's the predictability of this being able to, as Dr. Stover said, maintain the reduction. And I think it's been helpful for me to, prior to the surgery, say, I'm either going to go for a fixation or I'm going to go for a fixation of the anterior column and the quadrilateral surface, and not mess around with the articular surface and immediate go to a total hip. Because I think this is a situation, I don't pride myself on being a fast surgeon, but I think this is a situation where you know, at least in my mind, a 2 to 3 hour surgical intervention is the most that reliably you can do without getting into significant medical issues.
So Phil, would you be in favor of more of a Levine approach, some internal fixation and then a anterior total hip?
The answer is yes. I think the older I get, the more I like predictability. And I think that it's going to be the most predictable route. Though certainly I have You know, I usually tell patients with this particular fracture pattern, there's about a 20% chance that you wish I never walked through that door. And I say that to the family and to the patient to just have them understand that this is a pretty big deal. So I certainly have cases where I've done a Levine, fixed the quadrilateral surface, fixed the anterior column, put in a cup, and the cup is loose. In fact, I just saw a patient yesterday, but I still think it's probably the most predictable in this particular pattern.
I think another option to present would be the possibility of a supine anterior intrapelvic approach, some type of a quadrilateral surface buttressing implant along with an internal fixation of the anterior column, followed by a more either standard anterior or posterior, for that matter, total hip, either same setting or another setting. All right, John.
Yeah, I think those are
Mark,
all
before we leave
great
this,
points.
let me just ask the one cursed question that nobody will bring up. What about treating this non-operatively in a patient like this?
I think it's been established pretty well with some recent papers that the elderly with these types of fractures, they do not do well in terms of their morbidity of being bedbound and not being able to mobilize. Whether with or without traction, it frankly doesn't matter. They're tied to the bed either way. And so I think some sort of intervention I think is warranted. I mean, I think we kind of simplify it that this is just like a hip fracture in the sense that it's just the other side of the hip. And I don't think there's a lot of people considering non-operative treatment for elderly femoral necks or intertroches. And so I think we're fairly aggressive, appropriately aggressive in terms of trying to get some sort of treatment plan so that these patients can avoid the problems with prolonged recumbency.
Well, for me, hi, Dave Steven here. For me, if you elect to treat this non-operatively, this is a case where you mobilize protected weight bearing with a walker, and you don't keep them in bed. You get them out of bed, at least bed to chair for sure. And then you get into the consideration whether pain is an issue, and that's obviously a relative indication. But, if you decide that for comorbidities or complexity related to post-operative management, then this would be a case that you'd mobilize. And obviously the x-ray is not going to look very well, but I'm not advocating that. I'm just saying that if you choose non-operative, that would be the algorithm.
David, have you seen many patients being able to mobilize with fractures like this? I just haven't seen that. Have you had patients?
Well, I mean, they start obviously. Yeah, that's the dilemma.
So we do as well. I think.
I don't know if that was me or not, but
That was Stover trying to say something, but he doesn't have enough connection to get through.
oh, okay.
I got a connection.
Okay.
No, yeah, it's pretty rare. But again, you're starting off bed to chair, and then you're working that way. So I'm not saying that we do that frequently at all. Maybe once every several years, for sure.
Gotcha.
Yeah, I mean, I'll speak up and just say that we treat the majority of the people non-operatively.
The problem that you run into in that circumstance.
Sorry, Stover, we're not getting your comment.
No, my only point is I'm with Steve, but we treat a lot of them non-operatively. But if they do well and they get mobilized afterwards, it's a very challenging reconstructive case at a later time. So I think if they're relatively physiologically healthy, I would rather do it in the initial setting than a delayed setting.
Yeah, I don't want to belabor the point, but I'll just say for these people who fall down and have a very low energy fracture, my experience has been they don't have a tremendous amount of pain, and they can actually be up and mobilized fairly well. If she's in a car wreck, that's a different animal. And our total joint guys prefer to do them in a delayed fashion. So if they have pain later, they get a total hip. Having said that, the majority of them don't come back for a total hip. They do reasonably well. So I guess I'm an outlier in the whole argument that this is like a hip fracture. But the point is well made that I think that if they're an active person, it all boils down to their physiologic age and how functional you think they are, and how much pain they have and how much deformity they have, I guess.
I think, you know, a lot of those low energy injuries though that you're describing, Steve, are ones where the cortical displacements are not as significant maybe as this is. And there may be a lot of impaction, but the femoral head almost molds itself a new location into the impaction. And people do tolerate that situation quite well. This really has pretty dramatic columnar displacement that I think might not be so amenable to non-operative management.
Yeah, and that's what we thought too, Mark, in terms of putting his whole picture together. And so looking through this, I mean, those are our kind of discussion points. We haven't talked about those last two so much, but I mean, I think his diagnosis is an incomplete, meaning we saw that the internal iliac fossa was not complete, but it's a high anterior column posterior hemitransverse variant with just that little bit of caudal peripheral cartilage still potentially on the intact ilium. There's a large segment of the cranial impaction that we saw. This patient was put into preoperative traction for the reasons that we know about. And then when we talked about all the treatment options with him and his family and putting him together, he was not a candidate we weren't planning for an acute RF or any sort of arthroplasty. And so we thought definitive fixation was amenable for the reasons you mentioned, Mark, in terms of the large segment of dome, and it wasn't too comminuted. And so the chance of getting that into a reasonable location was with a high likelihood. And then I think we'll talk about it maybe intraoperatively in terms of the different strategies in terms of how to reduce overall segments of impaction in this location. And two different methods of how to do that. And so just quickly go through this, but this is kind of the stepwise thought of how I was trying to address this patient's problem. And I think that this is a supine anterior approach, like we heard from Dr. Williams and Dr. Stephen and Dr. Mayo, in terms of addressing anteriorly based columnar patterns through an ilioinguinal or some sort of anterior variant approach. But once the approach is done, addressing the impaction, getting some sort of backfill to maintain the reduction of that impaction, and then working down columnar stability. And we'll kind of go through these in a stepwise fashion. And so I think one popular strategy or one feasible strategy is to work through a fracture line to get access to visualize and or reduce the impaction. And this is just a picture from a paper by Archdeacon and his group out of Cincinnati, just working through an intrapelvic approach to get access. And I think I put that iliac oblique that we can see on the right in terms of, I think, really good visualization of that large impacted segment. And I think the talking point, I'd love to have some faculty's input in terms of how they're doing that, and in terms of the sequencing. Is it putting the columns back down, either the anterior column and then addressing the impaction? Is it both columns down and then addressing through some sort of cortical window and doing indirect reduction? Mark, any thoughts on that?
Yeah, I mean, I think there's been a couple of things described. Certainly, making a window above and impacting down from above always seems to be a little unreliable, particularly when you've got multiple, impactions. It's sort of like trying to tamp up a comminuted impacted plateau without actually visualizing the articular surface, and you just don't exactly know why it's not looking good, but all of a sudden you start losing your subchondral shadows, and it's because you're rotating or shifting your fragments. So that it's always a little bit less reliable than being able to tamp the head down like this under direct visualization. I think Gila Flam also wrote up reducing the anterior column first, and then sort of accentuating the posterior column displacement to work same through the fracture line. But at least you then have the femoral head and the anterior column sort of back in their normal position, and you've got something to where you can reduce the impaction to it. This situation of reducing the impaction first, I think, can work very well, but it mandates the femoral head has to be in the normal location, and that's sometimes a very difficult thing to judge when you don't have any intact segment that you can actually look at and judge the reduction of the femoral head. So how did you position the femoral head to be able to perform that? Or how do you?
Yeah, and so here's our patient intraoperatively, and we can see this is working through the intrapelvic window or the medial window of an ilioinguinal, and we can see working through both fracture lines. The anterior column is not reduced yet, and we can see that I think just like you said, Mark, getting a judgment of where the femoral head is in space is, I think, difficult, and I think we're getting maybe fooled here a little bit. I don't think, without the full CT to show you, I can't promise you, but this is not that segment of cartilage that we were planning on being intact. I think this is actually the more caudal down here is where that is. And we can see it maybe better on the picture on the right in terms of a slight difference in angle or projection, but that's that little impacted segment. And so, with 15 pounds of just distal femoral skeletal traction, we thought we had a reasonable alignment of where that femoral head is in space. And so without putting the anterior column back down and trying to work underneath that or work through the posterior column, we thought we had really good access, like we saw in that picture, to do just what was kind of described. And so we accessed that large segment impaction here with just a curved osteotome. We can see we can mobilize that segment and then push it directly down onto the head like we see here. And then looking at, just judging our head in space, there is, I think, this kind of more posterior lateral impaction that's free that we did not address for this patient. But again, we're kind of judging our head position based upon what we think is our intact segment, which is seen posteriorly here.
And this was with longitudinal traction only, or is there lateral traction as well?
This is pure just longitudinal.
I think it's really a good idea in situations like this. And as you pointed out, John, that as this intact portion of the sourceal becomes vanishingly small, it's very difficult to use this. But I try to get a perfectly controlled contralateral AP pelvis and then match my head position to whatever that small impact of source piece of sourceal is. And that's really a function primarily, not distal, but more lateral traction. And obviously, if this is trying to become a both column, if it actually made it, that would be no longer useful, except that you look at the midline to femoral head centered position to try to replicate that. But I think the lateral traction is really useful in most of these.
John, can I ask a question? How high, it looks to me like you've kind of gone kind of subchondral almost, and looking at the 3D, there was a lot more cancellous bone on that. So when you use when you use a punch from a window, obviously you're punching right down onto it. When you do this technique, you're kind of obviously trying to get as high as possible, but is there any significance to that, or does it matter? Or?
Oh, I think what you said is the perfect thing. I mean, I think we're working here through this window. That's our visualization, and so we're limited a little bit by the cortical bone that's still there in terms of trying to get a big shelf. And so I think the angle, we try to get as much bone as we can to keep that whole piece as truly one piece and to mobilize it and be able to control it accurately. I think we're trying to take as much bone. And so again, with osteoporotic bone, I think everything just kind of starts to compact easier than just a younger patient, obviously. But here we're trying to take as much bone as we can to keep it all contained within one piece and make our plan viable. And so moving on, we just, I think we're mobilizing and just here's one shot. And so it doesn't happen in one shot, but we're working and trying to get that back down on the head and holding it. And then once it's there, we can hold it directly. We can put wires, we can do other techniques to maintain the reduction that we think is adequate. And I think, as you can see on the right, I think in comparison to our what we're counting as the intact, I think that again, the head segment is down to where it's supposed to be. And then for this patient, I think maybe a discussion point or maybe not in terms of what to use, but we use a combination of cancellous chip allograft and just a synthetic calcium phosphate combination, just because of a significantly large void that was there. And so once that's done, I think we go down the algorithm that was discussed for the anterior base fractures. And so we're having anterior column reduction, and we can see just a modified pelvic reduction clamp through the anterior intrapelvic approach to get that anterior column back down to a cortical read on the brim. I think sometimes the tricky parts for that are for those incomplete fractures where the mobility may not be there. And I think for younger people that has the same phenomenon, it's not quite as mobile. For him, we were able to mobilize him, I think, adequately with a reduction on the pelvic rim and the articular surface through fluoroscopy, that we did not have to complete it. But that's always, I think, in the back of our minds if we're not getting that mobility that we're seeking. And so once that reduction's down, we're putting a pelvic brim plate that we can see here to act in buttress for the anterior column. And there it's just held with one screw initially to check the location and reduction and make sure we're happy with it. But then we go ahead and supplement with more screws to get good plate bone opposition. And then we start fine tuning that posterior column reduction. Initially, you can see on that picture on the left, we're not so much worried about the posterior column. We're more focused, I was more focused on the anterior column. And once that's down, we're happy. Then we start fine tuning the posterior column. And you can see, again, just the vector and the clamp that was needed to do it is not straightforward and simple. And you can see his bone quality is not good. And so augmenting the clamp with a foot plate and stuff was necessary to get that posterior column component back out and lateral. And then once we're satisfied with that, we move towards some antegrade posterior column screws that were been discussed. I think there's, I think multiple points of fixation is beneficial for this patient, just for the reasons we mentioned, to maintain his reduction. And again, I don't think we're planning on him being very compliant with restricted weight bearing. We're almost planning on him being mobilizing as much as he can tolerate. And so here we're going to put, I put two 3.5 millimeter screws and then one 4.5 that's outside the plate. And we can see that here. And then for his stability, again, we're adding and augmenting with multiple planes. And so here's an integrated anterior column screw. And then finally, the last step was to put an intrapelvic buttress to keep and maintain that posterior column that's been reduced and held with the posterior column screws, but again, to prevent further displacement from that medial vector. And so those are his final intraoperative fluoro films, and just a very limited intraoperative image through just a CRM that's been mentioned in terms of being able to get intraoperative advanced imaging, and just showing, I think, an adequate reduction of that marginal impaction just on those select cuts you can see. I don't have full long-term follow-up. He's a relatively new patient to me, but here's his final post-operative films or immediate post-operative films. And he was mobilizing in the hospital. He's been discharged to a skilled nursing facility currently.
So thoughts or techniques about internal fixation, stabilizing your impacted segment in addition to the allograft and substitute augment?
I think it's a great question, Mark. In terms of some sort of rafting screw or other implant to hold that help hold that impacted segment down, I think is good. I think we augmented with a large volume of bone graft, and then we were trying to get some sort of fixation through the intrapelvic plate. And I think it was maybe a sequence problem for us. But once we had our antegrade posterior column screws down, there was really a kind of a traffic problem with the screws that were resisting there to get any sort of fixation there. And so we didn't. I think it's appropriate consideration to try to augment that to make sure that, again, you've worked hard to get that impacted segment down, and then doing something to make sure it stays there is a very good idea.
Yeah, this is where I think that that having the middle window of the ilioinguinal open also offers you the opportunity to go straight anterior posterior with screws that are just above the impaction, that are out of the way of your posterior column traffic. Because you're right that, you know, having the buttress plate, having the posterior column fixation really eliminates a lot of options for internal fixation, but the second window opens up a different plane of fixation there. Question for the faculty. Corey Collins wrote up stabilizing the impaction with using long 2.0 wires from the AIP going just above the articular impaction and then bringing them out through the buttock, analogous to a plateau, a lateral plateau, where we bring wires out percutaneously out the skin on the medial side. And he's talked about bringing those wires out through the buttock and then backing them up so they're flush with the, you know, with the impaction segment. Has anybody tried doing that and have any points, concerns, or thoughts? No.
I mean, I'll say I've tried that just as you described, and I've been able to do it. I think sometimes just the location of the impaction and the vector that you're left with to safely place those wires, it ends up being a very low trajectory that's hard to keep within the stereo field. And so I think just the factor of where that has to be and what vector you're able to do with their habitus and their impaction in the vector, it can be challenging, but it is possible.
Yeah, I think his thought was then and that he could use them for a cannulated screw coming back over the wire potentially. But
Absolutely.
great. Other thoughts or questions from the faculty?
Hey, John, this is Ray Wright. I thought it was a great case, and one of the things that I think might have got lost to the audience, we're sort of talking about sequencing of the reduction of your of the impacted segment versus the columns first, and maybe you'd mention it, but I'm not sure. When you have a large impacted segment like that, a lot of times that impacted segment obstructs or keeps your columns from being able to come down. Have you run into that in your clinical practice at all? And was that really the reasoning for your sequencing here?
Ray, that's a great point, and it's absolutely true that sometimes that can impede your reduction. That wasn't the case here. That's definitely a possibility. Again, I think it's one of those hundreds of things that are running through your mind in terms of intraoperative decision makings, but it wasn't the case here, and we use that to primarily do as we talked about, just for the access. And so I think you're choosing your algorithm based upon a very fluid environment, but I think that's for sure something to consider, and we're always thinking about it. Thank you.
Thank you.